Hello, everyone. This is Dr. Mike Cho, Physical Therapist. Hey, today we have a special guest. Well, it's not a guest; she's like a mainstay here now, a little show. But we'll be back in a few seconds. Okay. Well, good morning, or good evening. Hey, today we got a special, obviously, Dr. Donna. She's like a neurologist here. And we got like a list of questions here. Well, first, our topic for today is what's up with all these kinds of dementia and staging. So we're going to ask her all these crazy questions. So without further ado, let's go ahead and bring in Dr. Donna. Dr. Donna, how are you doing? How's everything?
Good. Thank you very much for having me
Oh,
again.
you're no longer at the coffee shop, right? Last time
No, I'm
you
at
were at the
home
coffee
today.
shop, right?
The home
Well,
office.
it's me who is outside of the state right now. So we're kind of if we got cut off, we're just connected to the local Wi-Fi here. So, but how are you? How's everything? Everything surviving there in Houston?
We are. I think we had, a period of some challenges after this big hurricane here, and I think the people who are most vulnerable, um, as always, were disproportionately impacted. Our caregivers are among those people, and the people they care for are among those people. So we were busy trying to contact everyone to make sure everybody in our community of caregivers is safe.
I bet.
Yeah.
I bet. Well, I'm starting to share all this stream to our groups, but yeah, I'm gonna go back to our question and answer today. Um, Let me go back to here. I'm not that technologically savvy. So our first question, Dr. Donna, is it okay if I call you Dr. Donna? Call you Dr. Murphy.
Of course, you can call me whatever you like.
There you go. We'll just call you the amazing Dr. Murphy. So I was before I ask you all these questions, I was just telling my wife, I wish all the physicians that I know. I mean, most of the physicians I know are very passionate and everything, but I said I wish all the physicians I know, just like Dr. Murphy, telling me, "Hey, when are we gonna go live?" Something like that. You know, most of them was like, "I'm either shy or I got, I can't do this, I can't do that." But yeah, all right. So first question here, Dr. Donna, is why do we have to name the dementia if none of them have a cure? That's a great question.
Yeah, and I see a lot of people having a lot of curiosity about this question, and I don't think they even know why they have curiosity about this question, right? Um, so, from the perspective of a neurologist, I would say it's important to understand what specific kind of dementia someone has because it helps us to better um, counsel people on what the prognosis with that type of dementia may be. As an example, so the top four kinds of dementia are Alzheimer's dementia. At the very top, it's the most common. 60 to 80% of people have that kind of dementia. Following that is vascular dementia, which is often as a result of a series of strokes. That's how we think of it classically. Sometimes they're silent strokes, so you don't know that they've happened necessarily. And then you have Lewy body dementia, frontotemporal dementia following behind. And then you can also have mixed dementia, which is often Alzheimer's and vascular together, and that's fairly common as well. Um, one of those reasons, as I said, that we want to be able to identify which of these is likeliest to be someone's diagnosis is that it helps us to tell people, for instance, if they have a vascular dementia diagnosis as a result of major, like large blood vessel strokes in the brain, that the lifespan of that person is likelier to be shorter than the lifespan of a person who has Alzheimer's type dementia, right? Um, and that's important to know in terms of what we can prepare for emotionally as well as practically. I think a lot of this diagnosis, pushing it earlier and earlier, I think the benefit, even when we don't have a cure, is that we have more opportunity to plan. To prepare in really every way. So that's one important thing. I think another important thing in identifying exactly what kind of dementia someone has is that most of our therapies are especially for the purpose of slowing down the progression of the disease. Now, there is no drug that actually will stop or reverse dementia, unfortunately, which is, again, the reason why we're trying to push diagnosis as early as possible. most of these drugs are developed for Alzheimer's type dementia. And, if you look at it by the numbers, that makes sense because most people suffer from that kind of dementia as they age. Unfortunately, it means the other kinds of dementia kind of get the short end of the stick, right? Like they don't have a lot of drug therapies. And I will say here, I think it's important to note that the drug therapies that do exist are super modest in the effect that they have. I often am talking about the importance of behavioral interventions, but those too, like as soon as you identify what is going on, in this case, I don't know that it's as important to identify the different, like to discern between the different kinds of dementia. For behavioral interventions, you probably want to do all of those things that you would do in Alzheimer's type dementia. You would want to do those same kinds of things for vascular dementia, et cetera, et cetera. Those kinds of things, which I think I just discussed on the last interview or Q&A, are things like, making sure that you have as much education as possible to build up what we call that cognitive reserve in the brain, making sure that you're taking care of your high blood pressure, diabetes, high cholesterol. If you have obesity, then losing weight, making sure that you're not smoking, making sure that you're not consuming alcohol or at least excessively consuming alcohol, protecting your hearing because hearing loss is associated with dementia, making sure that you are not putting yourself at greater risk for depression. That's also associated with dementia. Exposure to air pollution, all of these kinds of things, right? Traumatic brain injury, they're all risk factors that, again, once we know, like this looks like it might be dementia, these symptoms that we're observing in our loved ones, this change in memory or thinking or speech or personality or behavior that are functionally limiting, they're related to a person aging. Once we identify that it's likely to be something like a dementia that's going on, then we want to make sure that we're, really going after those behavioral risk modifications as well. So yeah, again, for planning purposes, for, knowing what therapies to put people on, there are also some drug therapies that are for symptomatic control, and they have been specifically tested in dementia. And again, usually this is in Alzheimer's type dementia where we see most of this testing being done. So again, in order to give people a clear idea of what would be maybe the best course of action for their loved one, it is nice to have a specific dementia diagnosis.
That's so true. That's so true. Thank you for pointing that out. For those people who are watching, comment live, people who are on the replay, comment replay. So I'm writing things down too, Doctor D. So yeah. So again, dementia is like the umbrella term, and underneath that, you got different types of dementia. Obviously, like what Doctor Donna said, the most common type is Alzheimer's. So I love what you said about cognitive reserve. Yes, they may one part of your brain could be affected. Let's just say it's an FTD type of dementia, frontotemporal. You can obviously still work on the other part. Stroke patient. If you have a stroke patient who have a spastic upper left or right upper extremity, yeah, you can work on that affected extremity, but work on the other side so they can compensate for it. And same thing with the cognitive reserve. Work on that remaining part there and just make it stronger. And of course, exercise, that's where we come in. Physical therapy, exercise, very
Mhm.
good to improve that circulation to the brain. She mentioned vascular dementia, ladies and gentlemen. Vascular, what does vascular means? Blood flow. And if you lack blood flow, like what she said, she had a stroke or TIA or whatever, there's lack of blood flow to the brain, then you can get vascular dementia. So thank you for pointing it out, Dr. D. So, and of course, she mentioned the question here. Question here. So the question is, why do we have to name the dementia if none of them are cured? Yeah, there's specifically no cure yet. Yeah, it's irreversible. The true Alzheimer's or true dementia is really irreversible. But what if? Let's just say, what if that type of Alzheimer's dementia with cognitive impairment is what you call reversible type, like depression or delirium or UTI. That's reversible. Then the doctor, the physician could address that. Then hopefully, oh, it's not just. I'm not saying just. It's depression, not dementia, right, Doctor D? All right. The next question here. This is a great question too. What do the medications in dementia help do? Did they work in all dementias?
Sure. So I alluded to this in the prior question, and that is that none of the therapies that we have so far. So there are a couple that are kind of the older kinds of medications that we've been using for decades now. they are generally prescribed when people are kind of in the mild cognitive impairment, maybe, but more so kind of in the mild to moderate range of dementia. So the earlier to mid stages of dementia, we think that these older medications and even the newer ones are going to be most impactful at those stages. Um, they don't stop the disease progression. They don't reverse the disease progression. They can only slow that progression down. That's also actually true of the behavioral interventions. That, as I said, those behavioral interventions are at least as powerful, if not more powerful. From everything that I see in the literature and what I've observed anecdotally in patients, people in my family, even who have dementia, right? So that composite of like knowledge that we have, the kinds of knowledge that we have, it's really clear to me that those kinds of interventions are super powerful. They're also difficult, right? Which is probably why people at the end of the day are just accustomed to asking for a pill to solve their problem. So yeah, we're very limited. The newest kinds of medications, which are this class called the monoclonal antibodies, they all have like the same ending in their names, in their generic names. They also only slow down the progression of disease. I think it still remains a question as to how effective they are, and they carry pretty substantial risk, unlike the older medications that we have. So yeah, I mean, we can talk about that some other time maybe, but that, people who are interested in the latest dementia medications, again, these are for Alzheimer's disease, and they're only for early stages. And there are other things that are going to disqualify some people as well, from getting the access to those medications. Yeah, but there are a lot of challenges, I think, with those newer medications.
That's so true. That's so true. Thank you for pointing it out. And also, I like what you said about symptomatic control with regards to that question, the question that medication wise, like what we talked about earlier. If the patient has UTI, address that UTI, and that because UTI can aggravate your loved one's uh, behaviors. We're not talking about Alzheimer's and dementia. We're talking about the behaviors of your loved ones. So if they got UTI, their confusion will get worse, their anger, their
Yep.
their behavior is just going to get worse. So address that, the UTI part. And let's just say stroke too. If they're not taking their blood pressure, their antihypertensive pill or their blood pressure pill, guess what? They're going to be hypertensive. They're going to get some strokes,
Mhm.
mini strokes, TIA. Guess what? Lack of circulation to the brain, they get mini strokes, their dementia is going to get worse. So, and same thing with Parkinson's type of dementia. If they're not taking all their Parkinson's meds, their tremors, their fascinating gait pattern, their walking, it's just going to get worse too. And they fall and they hurt themselves and they cannot express themselves. Hey, I'm hurting. I hurt my something. I hurt my hip or back, and they can express. Then they have more behaviors. So address, it's what did you say here? Symptomatic control. That's very important.
Yeah,
Yes, there's no treatment or thing that, but you control those symptoms. Then you
exactly.
can take care of your loved ones more. So, right, Dr. D?
Exactly. Yeah, and I will say again here, the therapies are not necessarily medications. They're not necessarily pharmacological therapies. They could be behavioral interventions. Again, I try to emphasize this because that's always what we should go to first. There are always side effects of drug therapies, and there are really not so many side effects of some of the behavioral interventions that we do. They might just be more difficult to execute on. Um, but yeah, I absolutely think it's important to understand that there are things that we can do to reduce symptoms in dementia that can actually have, like great benefits. So, for instance, people with dementia have sleep disturbances, right? And I've seen that in my own family with my grandmother, and how she comes into my mother's room, or when I've stayed over there, she will come into the master bedroom at 2 in the morning and start rummaging through her clothes, having a little fashion show in the room. Um, and that's lovely for her, but it's very disruptive for me. And ultimately, what it can mean for people whose own sleep is disrupted in that way is that it causes behavioral disturbances during the day, as well as at night, right? And because they're not getting good sleep. So there are lots of things that we can do to make sure that we have a routine for sleep that attempts to actually regulate them better. And it's still a challenge, right? It's still a challenge. But things like, putting all electronic devices away. If, my grandmother is watching YouTube, like videos of Korean music and whatnot during the day, but not
I hope
allowing
it's not K-pop, right?
no, it's
You go
traditional
crazy.
Korean music.
Just kidding.
um, but yeah, she's really engaged in those things during the day. But it's important to kind of, like with our children, to take those things away as we wind down for the night, and make sure that we have a routine that is calming, that is a routine that's regular, right? And that might look different depending on who your loved one is, and like what is it what is the routine that actually makes them comfortable and prepared to actually turn in for the night. um yeah, that can be tea, that can be like a, soft music. You don't want to be like having somebody be very physically active near the time that they go to sleep. But it is actually important to be physically active during the day so that they actually tire and are seeking to be rejuvenated with sleep. So things like that. There are ultimately people who find that they have to resort to medications, and there are a lot of limitations, a lot of side effects of those medications. But when I say that there are a lot of options for symptomatic relief, so that hopefully, you can maintain the health of your loved one as well as your own health. There are a lot of options, right? And you have to talk to your doctor about what is most suitable for your loved one at that point in their illness as well. Yeah, and then aggression, anxiety. There are lots of other symptoms, apathy, depressive symptoms that we can manage again with behavioral interventions as well as with drug therapies. So people feel very, I think, exasperated by some of the symptoms of this disease. And it's really not the case that there is nothing we can do. There are things we can do to slow down the progression of the disease as well as to address each of the symptoms as they come up as the disease advances.
That is so true. That's so true. Let me tell you a funny story here, Doctor D. So my grandmother, she had, of course, back home in the Philippines. We all thought that Alzheimer's, dementia, are just like crazy people, right? I mean, that's what we thought about it. It's like, oh yeah, she's just getting crazy. But I remember this specifically. My grandmother. So me and my best friend, we were playing video games. We called family computer. So back home in the Philippines, or Atari. I don't know if you know that. So
Yeah,
it's
yeah.
80, okay. So Atari, and we were playing, and then me and my friend was like, "Go ahead and shoot that guy, kill that guy." Of course, in the Philippines, we don't have a he or she. It's just directly just kill that person. No, we don't have a he or she. So her head, she thought that we were going to kill her.
Mm.
So, and then my mom or my grandmother went to my dad when my dad came home. It's like, your son is about to kill me, man. He and his friend, they're plotting to kill me, blah blah blah. But we were
Oh,
playing video games. And
right.
then during the day, she's just laying down there in her bed, and just lay down there and not do anything. And then at nighttime, you were mentioning it, at nighttime she would stand up, and she cannot find the restroom, and she will just do number one and number two in the living room,
Mm,
because she can't find her way. And we thought she was just the Philippines. We don't, up until now, we still have to spread information back home in the Philippines. Hey, this person is not just going crazy, and there's something going on in the brain called Alzheimer's or dementia. So
mm,
yeah. I also like what Dr. Donna talk about, behavioral interventions. Again, most of the time it's the caregiver's approach. If you come in, so let's just say your client or your patient is sitting down and you're standing tall over them, and then your arms are across the chest like this. And if they have a different culture, and if you don't, some cultures, they don't like people having their arms across their chest or their arms across on their waist like this. Even your own eyebrows, if your eyebrows are like this, approaching them, they'll think that you're upset at them. And of course, these patients that we have, they're all reactive. And once
right.
they see that you're how you approach them, so it's very important that you also approach them on an eye level. If they're in a wheelchair, they're kyphotic, they're leaning forward like this. Why stand over them? They cannot look up. When they look up, they could get dizzy or whatever. So it's very important that you go on their eye level too, not just physically on an eye level, but emotionally too. Their function has gone down, both their
Right.
brain function. It's literally brain failure. Just like a heart failure. You got kidney failure, heart failure. The brain is failing to function, ladies and gentlemen. So this is where Dr. Donna comes in. So thank you for pointing that out, Dr. Donna. That's not just about medication wise, therapeutically. There's also behavioral intervention, physical therapy intervention, occupational therapy
Yeah,
intervention. This is very important. So you need to approach and talk to your healthcare professional who knows what they're doing, obviously, right?
right.
Number three question, Dr. D. Why do we stage dementia? Does that help me understand how long my loved one has left? That's a great question too. So,
Yeah, and I think people believe that, and that's why they're so, um, I think, consumed by understanding what stage their loved one is in. I see this a lot in these Facebook groups where people will state, in their posts, "My loved one is in this stage. This is what they're doing." Um, how long do we expect to deal with this kind of thing? How long do they have left? Because it's difficult, right? It's challenging, the different kinds of behaviors that people are disclosing in those spaces, and yeah, it's unfortunately, there's not a great answer for this in terms of saying like, "Oh, if you're in the more advanced stages, like stage 6, it means that you have 2 years left, or it means you have 6 months left." Nope, there is really no way for us to say that. My own grandmother, the other grandmother who actually has passed, many years ago now, she I think she was in the final stages of disease, which, not everybody knows if they're not there yet, or if they're not looking back at what has happened to their loved one throughout the course of this illness. They don't necessarily know what the final stages look like, if you actually get there, right? And some other illness does not actually take your life. Um, that can look like someone who is nonverbal, somebody who is full assist in eating, any kind of hygiene, um, going to the bathroom, bathing, like any of those things. They may also not be able to move at all, right, without assistance. In the case of my grandmother, for the last, gosh, at least 5 to 7 years of her life, she was pretty significantly immobile. She was kind of contracted in her bed. Um, and this is what this looks like at the most advanced stages. Now, my grandmother stayed in that state for, as I said, 5 to 7 years. So depending on kind of like the quality of care, the other kinds of the care environment included, the other kinds of medical illnesses that person has, which may also those things may be the limiting thing, right? Just like I mentioned, as in vascular dementia, when you're having a series of strokes and you have a dementia as a function of those strokes, it may not be actually the dementia that ends your life. It's
mhm.
the strokes. Yeah,
That's so true. That's so true. I like what Dr. D said about the quality of care and the quality of life, ladies and gentlemen. So, uh, she mentioned about her grandmother having, quote unquote, being on the end stage, and the quality of care will actually dictate how long your loved ones will survive, because you can have an early stage patient who has just a simple MCI, and you're not taking care of the blood pressure levels, you're not taking care of the blood sugar levels, guess what? They're going to pass away. That's early stages, MCI. And you got this patient who was bedbound, total assist, total dependent, bilateral upper extremity, lower extremity, in a decorticate, or they're in a flex position already. But the quality of care is top notch. No wounds, no pressure sores. They're taking care of the medication. They're feeding her well. She may be in feeding tube or whatever. She's on the end stage, 6, 7, something like that. Total dependent, can last 5 to 6 years. So it just really depends on the quality of care. It all boils down there too, ladies and gentlemen, how you take care of it's called comorbidities. So it's very important that you go to your primary doctor, you talk to them, hey, what are the other stuff that we can take care of? And that way, we can still extend the life of your loved ones. Now, here's the thing: there's also what you call end of stage. If they got kidney failure, total heart failure, you might also want to consider hospice. So, Dr. D, I know this is not part of the questions, but when do we consider hospice? I mean, how does that work as a physician? I mean, how do you determine that, hey, is my mom ready for hospice or what? So.
Right. This is a tricky question. It is one that comes up often. I think there's a lot of misunderstanding about what hospice is and what it looks like in dementia specifically. So, hospice and dementia, I know so many people, including my own grandmother and my grandfather, who have come on and off or in and out of hospice, right?
Mhm.
Because the doctor, when they actually I guess, prescribe that, suggest that that be done for a patient, that is with the expectation potentially that that person may have less than 6 months, right? So obviously, if you have like florid, like, organ failure, like a kidney failure, like a congestive heart failure, something like that going on, which are related to, but not dementia, right?
Mhm.
Um, those things really might limit the length of your life, right? And that can be pretty substantial in the ways that that limits the length of your life. And so when we decide, this person doesn't have more than 6 months, or potentially might not have six more than 6 months, we might put someone on hospice. Now, I'm going to be honest with you that I have definitely seen this happen where, certainly a strong argument could be made that this person is going to survive past 6 months. But because of the circumstances for the family, the kind of care that they require,
Mm.
um, you are in shared partnership with your doctor. And if your doctor is savvy about the systems that fail us, they may prescribe hospice. They may make an argument for why this person may have less than 6 months, right?
Mhm.
Even again, as I said, if there could be a strong argument made in the other direction, so you don't have to be freaked out that like they only have 6 months. If it doesn't look like they have an imminent threat due to like organ failure or something like that, it is a way sometimes for us to get resources to people, because hospice can be super helpful for the primary caregiver, especially to relieve them a little bit, to have someone who is trained in healthcare come in regularly to help bathe your loved one. They can provide, things like adult diapers, other kinds of resources that we need in the care of our loved ones. And, I know people, including my grandmother, who have been on hospice for 18 months, a
So
couple of
true.
years. So, and then sometimes they will come in and out of it. Sometimes they'll have a hospitalization, they'll be put on hospice, right? And then they get better, they can come off hospice, then they have another insult and they have to go back on hospice, where it's helpful to be back on hospice. So you need to work with your physician to see, like, can that help you, right? To have that those services in place. um, and then I think it's important to understand that once that is in place, what that actually means is that you're not actually going to get care or interventions with the purpose of extending life, right? So on hospice, you're not going to get therapy for like whatever, chemotherapy for a cancer with the purpose of extending your life. Therapies that will be prescribed, many different kinds of therapies, are those that will mitigate suffering, right? That will make people comfortable. Sometimes they have a dual purpose, right? Like, so even though they may be prescribed for the purpose of comfort, they may also help you get better. So, for instance, one of our caregivers right now in our community, her mother has an aspiration pneumonia, right? And that they are treating with antibiotics, like very seriously. You can make an argument, well, that's for the purpose of her having extending her life. Well, yes, it has that function. It serves that function as well. But it also serves the function that she is very uncomfortable, right? Like, she is not breathing well, she's in distress, and so they're treating the underlying infection to make sure that she is comfortable. And that is the fundamental purpose of hospice.
So true. It's so true. I like you mentioned about that. Because we personally have some patients that we see in hospice. So remember, the goal of hospice, ladies and gentlemen, is not restorative. It's more like comfort care. So we specifically see some hospice patient. We don't ask them to go, hey, do some jumping jacks and cartwheels and let's walk and do like a mile of walk. No, most of the time we're like helping them sit at the edge of the bed, simple massage, simple stretches, especially for those people who are tight and contracted. Would you just let your mom be tight and contracted? No, you kind of do some gentle exercise, gentle movement, and that way they're still comfortable. That's the key there. And then, like what Dr. Donna said, there are patients that come in and out from hospice to restorative care. because again, it goes back to what she said, ladies and gentlemen, the quality of care. Because let's just say your mom or your dad or your loved one who doesn't have good care, and then hospice comes in and all these therapies comes in, pain management, simple exercise, range of motion, taking care of the other crucial issues, then they get better. So all the other comorbidities are controlled. Then they kind of restore back to their previous baseline, not the 50, 60-year old, but the previous baseline of maybe 6 years or 6 years, 6 months or 8 months before this happened. So that's very good. Dr. D, we got one more question here before I let you go. I know you're a very busy neurologist there. At what stage do we need to start thinking about transitioning to more dependent care? It kind of talks about that hospice care too. So, right. So, yeah,
Exactly.
at what stage do we need to start thinking about transitioning to a more dependent care?
Yeah. So I think that we need to be thinking about several things here, right? It's not just the state of our loved one, it's also our ability to care for that person at that
Mm,
particular moment, right? So, um, basically, like our own health as caregivers and the resources that we can continue to muster to care for this person. Um, this may again be something where whatever transition happens is not a permanent transition. And I think that it's important for us to understand that that is an option, that we can actually have people for a period of time. For instance, when somebody is acutely hospitalized, right, because something happened to them, right, like they had a fall. And so that they have to be treated. And now the best place for them is temporary. And it allows them to actually recover with all of the services that they need, like very accessible to them, right? In an inpatient recovery context. That can be really helpful as a temporary solution to getting that person as close to their kind of pre-injury baseline as you can before they come back home to you. There can be things that are more permanent, right? So now you're looking at, okay, you know that this disease is advancing. You know that it's only going to create even more, you know, it's going to be even more costly in terms of the health, the social, and the financial toll for you and your family. And you decide that that's not something that you can continue to engage in the way that you have been engaging to date, right? That now you have to kind of move them into a different situation where you're going to get a lot more assistance with them. Those transitions, again, it's like it is looking at kind of the patient caregiver dyad and the family context to understand, like, when is that moment that we need to do that. I really often say, and I don't know how satisfying this is for people, because I think sometimes people are looking for like a kind of formulaic answer, or a check the box kind of, like an algorithmic answer for like, when is that moment, or what is the thing I need to do exactly. And it's just, for me, I have found that it is really about like our gut. Like, it's like you have all of this information that your own brain is actually integrating in order to generate a feeling that is kind of subconscious, right? But it communicates to you like, this feels like it's the right thing to do in the moment, or not. And I think often that is like more useful to kind of drive our decision making. I think it's still okay and a good thing to think through it rationally and to plan, especially because I think these transitions of care are not, I know these transitions of care can be very costly, like in money. And they take an emotional toll, right? Like, deciding to put your loved one, especially if you come from a community where this is very uncommon, and it's kind of like, it's kind of culturally internalized that we are to care for our loved ones in our homes. And I think in general, that's true. I think across the board, if we could all do that, if our society helped all of us to be able to do that in a sustainable way, in a way that wasn't so taxing as it is for most of us who do this care at home, then I think that would be the best solution. In all circumstances, it's to keep people as independent as they can be for as long as possible in the community, and then to transition maybe with some help from the family into a different care context, where they're still out in the community, and maybe to stay there indefinitely. But that's not the reality. because again, there are so many systems that don't support us in the way that they should, like in terms of like publicly funded resources and whatnot. We end up having to figure out alternatives that maybe not ideal, but they're the ones that are going to be most sustainable and safest for our loved ones and for us. So yeah, it's kind of, I'm sorry I can't give like a very discrete answer to this because it isn't a decision that is made in that way.
That is so true. That's so true. It's very, like what you said, it's very, very tricky. The key here is, plan as early as possible. It's very
100%.
important that even even us, we're 40s, we got to plan. If you fail to plan, you plan to fail. So what has happening is that our grandparents or our mother, they don't even have a POA. They don't even have stuff like that. The legal paperwork. Who's going to take care of the real estate? Who's going to take? And then all of a sudden, the government comes in and takes it, and then now nobody knows, and everybody learns by their own experience. So the support group is very important. Keep asking questions in our Alzheimer's group. Um, there's this box that I've been seeing in my Facebook ads, Dr. Don. I don't know if you see it. It's called Knox Box. It's like a fireproof box, and everything there kind
I've
of
seen something
forces you
similar.
to,
Yeah.
yeah, forces you to start your affairs. Hey, where can I find my life insurance policy? Where can I find my actual social security card number or my
Right.
Medicare card number? Who's going to be the next in kin if something happens? It's really good. I really want to create it myself, but why create it? It's in Amazon. It's called Knox Box, and it's there. You
Yeah.
got where the what you call this, the car paperwork, the real
Right.
estate paperwork,
Right.
who's your lawyer and stuff like that. And it's very important that you have that as early as now. And because sometimes, not sometimes, most of the time, when you start, going to the nursing home or assisted live or a nursing home, some of them, they would get, what do you call this, 5 year, 7 year look back period if you sold your properties or not.
Yeah.
So we had that in the nursing home that now they've lost all their properties because, they kind of haven't figured out their affairs. So it's very important that you do it as early as now. Again, you failed to plan, you plan to fail. Dr. Don, I know you're very busy. Thank you very much again. Where can they find you? Where can they reach you? Any email or website that they can go to reach out to you?
Sure. So we're on Facebook as well. So our Facebook page is facebook.com/prognosis, spelled in this way again, because we believe in the power of us together to kind of navigate this very long and difficult journey with dementia. We also have a webpage that's www.prognosis.com. You can reach us there through the contact page. We have a lot of free resources there. We have a caregiver storytelling library that actually are real stories of a diverse group of caregivers who talk about each of their experiences. And that content is organized in terms of the most important themes in dementia, really, the symptoms that people witness, have to manage, some of this planning that Mike is talking about, which is so crucial, right? Like that last question on transitions of care, like thinking about what that actually entails to make that happen so that it is an option for you financially and otherwise. It is best to start thinking about that very early on. We have communities of caregivers that are facilitated through chats as well as on weekly caregiver check-ins, virtual calls, Zoom calls. And those are also spaces where you can start to think about these things in bite-sized chunks. So it's not overwhelming, right? We talk about timelines basically for like when you first start suspecting something is going on, what you need to start doing to investigate, to obtain a diagnosis, why that's important, all the way to like, what do you do, I think we have some content in our caregiver library actually about writing a eulogy, like
Mm.
it takes us to the very end of this disease. And it's super helpful and it's very, very relatable. So I would ask, people to check that out, plug into our communities, which are low cost subscription, accessible by design, because we wanted to make sure that that would not be a deterrent to help support our caregivers.
Well, again, thank you very much, Dr. Don. I appreciate you. But before I let you go, ladies and gentlemen, always remember the word fast, FAST, letter F. Find people that will bring out the best in you because you are the average of the 5 people you hang out with. Okay. So specifically find, services that will bring out the best in you and your loved ones. Okay. Next letter is letter A. Take action. All this stuff we're doing is not going to do me good. It's not even going to do Dr. Donna good if you don't take action. Take action. Go to their website. Take action. Go to your family doctor, PCP, or whoever is taking care of you and your loved ones. You know, you care. Be you being a caregiver. You got to take care of yourself too, because you cannot give what you do not have. Right. Next letter is letter S. You know, share and subscribe. Go to their website, prognose with the US us.com. Is that correct, Dr. D? Go to their website, go to their Facebook page, you know, read on it, right? And then last but not the least, letter T is teach it. Why? Because when you hear it, you forget. When you see it, you remember. But when you're actually teaching it, you're actually understanding it more. And that's how you become, that's how you understand Alzheimer's or dementia. Again, thank you very much. Thank you, Dr. D. Appreciate you. Be awesome, be great, be excellent. We'll see you in the next episode of the Prognosis Show. All right. You have a good night or good day. Bye bye.